And then I'm going to share my screen. Okay. All right. So this is just a reminder that if you have any upcoming out of offices, please feel free to use the Confluence calendar to enter that in so that we know who will be available for the call and who will not be. And another reminder, December 26th, we will not have a call. And as we know, on January 7th, Nancy, Ricky, and Manjula are going to do a presentation on wound cultures and specimen cross-mapping table. So that's very exciting. Does anyone have any updates or topics that they'd like to discuss before we jump into the specimen cross-mapping table? Okay. All right, so let's just get right to it. So Amy's not able to attend and neither is Raj, just a quick update there. So let's start with this term, the blood-tunneled central venous catheter term. So I'm actually not sure why this is highlighted pink. It just says fields not finalized, but the fields that would be needed to be finalized or discussed would be in pink, and they're not. So I'm not sure. Amy had told me that in these situations, if no other like field is pink, then this is just something that she hasn't gotten to like clean up and like make it like green. But before I did that, I wanted to bring this up with the group in case you guys had, remembered if why these fields were not finalized, if they were not. So let me just go back to the beginning. So this is the term.
Yep. I mean, it's usually tunneled to prevent or to reduce the possibility of it getting contaminated or colonized by bacteria. So it would be the same. I think we would have the same fields as we do for central venous catheter, but there may be a few, like, there might be a different code for it, a different SNOMED code for it.
Tunneled versus central, tunneled central
Yeah.
venous catheter versus CVC. Okay, so
So, Krishna,
yeah.
sorry, this is Manjula. So, so I think this is my assumption, kind of a guess, but I think we had all these catheter terms incomplete previously, and we worked on it later on. So I think that pink section at the end of the row is something that was that's remaining from our previous work, where we kind of completed all the catheter terms, and then maybe forgot to kind of correct that those two pink ones that we worked on it. So maybe that's what happened. That's my guess. Because if it is if it is a specific field, so usually if I can remember right, most of the database added to database and not is I added them because when I was adding to the database, so usually if it is specific field, I usually say SPM 5 or whatever field is not complete, or there's no definition or something specifically is not missing. But I think it says fields not finalized. I think it's I was talking like generally, because that catheter, the entire catheter related terms are not complete some time back. So I think this is remaining from those times.
Okay, so basically this has already been resolved. It just we forgot to clean it up. Is that I mean that's what I remember Amy telling me when she, asked me to help her clean this up, but I wasn't sure because I took notes when she was going over this with me, but that part I remember her saying it, but I didn't write that part in my notes. So I was kind of like, well, let me just bring this up with the group in case that's not, the situation. So, but you're saying that this is fine. I just need to change this to, make a note basically saying like Amy to add to the database or Manjula add to the database or, like change the color to orange or green or whatever.
Yeah, it says like added to database, keep the added to database. No, because still not been added to the database, but then the other one, like, it's completed, like, can be added.
Can we see that, Manjula, just by selecting the fields? Like, can we see it in the database?
Yeah, we can access the database and check it. It's just that I can't do it now. So CDC systems does not allow me to access the database through CDC systems. So I have to sign out of the CDC access system, which is Zscaler. I had to sign out of Zscaler, and then I have access. So I have to sign out of the meeting, sign out of Zscaler, access the database. Yeah, that's
No, I'm not going to make you do that. I just but there is a correction on here. It should be IDSA, not ISDA. If you go back to the beginning. So it's Infectious Disease Society of America.
What field was that? The definition.
And I'm pretty sure this was not added to the database.
You're pretty sure what the IDSA and NHSN wasn't added to the database?
No, this term was not added to the database, so it's not yet in the database. I'm pretty sure it's not yet in the database, so it will go to the database with the correction. So yeah.
Okay, perfect. All right. Easy enough. Okay, next one. I don't know what this next term is. Let me go back here. Okay, catheter tip umbilical catheter. Let me go to the comment here at the end. Should SPM 10 be structure of umbilical artery, body structure, and coordination be full? So specimen 10 is specimen collection site. Let's see. And then should it be full coordination? So this is what we have so far. Catheter tip for SPM4. And then for specimen type modifier, umbilical catheter.
So what's the question?
Is if we should put the SNOMED code structure of umbilical artery body structure in SPM 10, which is specimen collection site, and if the coordination should be full instead of partial.
John, do you have an answer for that?
I don't, because I don't know what the actual collection site is for that.
Okay.
It could be artery or vein, if
Right,
I remember. Yeah, so
So, I mean, we do have a structure of umbilical cord stump, but that doesn't specify, and I don't think that's going to be correct either.
Okay.
Right, because they put the catheter into either the umbilical artery or the umbilical vein, and I think they just do that on neonates, newborn babies.
So we could, since we don't know at this point, I would suggest that we actually go with the concept that I put in the chat,
Okay.
because that subsumes both artery and vein.
Mm-hmm. Okay. So is one of the questions, should we have one for umbilical artery and one for our umbilical vein?
Yeah, I was thinking, is it important for the lab to know whether it came from the artery or the vein?
It might be
Yeah.
For a
important.
well, I don't know. Do you ever do blood gases from an umbilical? If so, then yes, you'd have to differentiate.
Okay, I don't know. I'd have to Google that because I'm not super familiar with blood gases on babies.
I have done blood gases on babies, and so yeah, we did. I think we do need to make that distinction.
Okay.
So,
Thank goodness somebody knows.
It's been a few years, but I have done them.
So I think either we can create two uh, by like pre-coordinating, or we can. So this one allows the one we currently have. This allows the sender to specify where the sample is taken from. If you look at required fields, so we can keep this and then post coordinate it, or we can pre-coordinate and have two. So that's always like a choice we have to make, every time. So whether to pre-coordinate or to post coordinate. And I think my comment there, towards the end, that was based on, if you look at the comment, it says site umbilical artery. I don't know where that right there, Christina, it says like site umbilical artery. I don't know where that uh, the last piece in the comment came, but it says in the comment site umbilical artery. I made the comment towards the end of the row based on the site umbilical artery on that comment that's currently highlighted. But based on the discussion right now, it has to be either. So I think we can, again, going back, we can either create two and pre-coordinate, or create one and post-coordinate.
Which one is better? I mean, does it matter which one? If we do one row and post coordinate, or two rows and pre coordinate?
That's.
Yeah, I guess which one's better?
I think we previously taken the approach, like, if it is a very common um, um, specimen that is frequently ordered, and post coordinating all the time, like asking the ordering provider, or whoever that's creating the order, to always pick something so that the system has to should post coordinate, we pre-coordinate those so that the burden is less. And then for the rare ones, we kind of keep them for system to post coordinate, so we can keep the number of individual specimen terms less. That was the approach. So I lean into having post coordinated because this is kind of a rare specimen. But I'll yield to the team.
Well, yeah, I thought it didn't have necessarily be rare, but to not have so many lines, we were post coordinating instead of trying to pre-coordinate because we were having to add too many lines, I thought sometimes, even when it was common.
Okay.
So umbilical cord blood would either be the vein or the artery. I'm remembering something about the fact that umbilical cords, the artery and the vein are actually reversed. Like oxygenated blood goes through the vein and non-oxid. So I don't know, I looked this up, but I would have to do a little bit more research. It says you can get blood gases from a baby from a heel stick, from an intravenous cannula, more accurate from an umbilical vein catheter or a central venous catheter than peripheral IV, and arterial sites. Indwelling arterial line, arterial stabs can be taken from the radial artery. That sounds horrible.
That's what I was thinking. That was the word I was going to use, horrible.
And peripheral arterial stab from the brachial artery. So at any rate, so we do need to know where it's coming from, it sounds like. But there would just be two. There would be umbilical artery or umbilical vein, right?
Yeah, and I have those both in the chat.
Okay, perfect.
So we're saying 2 rows?
I think 2 rows, yeah. And they're both separate SNOMED codes? Okay.
Okay, so then if I'm going to copy this row, is everything going to remain the same? Oh, go ahead, Angel.
Wait a second. So the specimen is a catheter tip specimen.
Right.
But catheter, I think this is for, can you hear me?
Yes.
Yeah, I don't know why this. Okay, there was a warning saying that connect to your speaker or something. So I was curious. So catheter tip is usually sent for culture, isn't it?
Yeah. Yep.
So the the test for umbilical, the test for blood gases is a different test, or am I
right?
confusing myself?
No, you're correct. Catheter tip would be like a roll, Mackie roll, or a sonication. And so, yeah, we have a bunch of catheter tips in there. So what we would do is, I mean, we have a preferred name here, like it's coordinated, right? So you're suggesting that we just have catheter tip and then tell people they have to tell us where it's from?
Yeah, so I was kind of going back to our previous question, like, if you're doing the culture for catheter tip, again, going back to the previous question, is it important for the lab to know whether it came from the artery? I'm just asking. I think it's important, but I'm just asking, is it?
No, it is important. Yeah.
Okay. So again, I think my suggestion is that we post coordinate, but again,
okay.
please very very frequent, we can pre-coordinate as well, like, have two for artery and the vein. But I suggest we post-coordinate and ask people, like, let us know where it came from.
Right.
Okay, so then this coordination would be changed to full.
If we post-coordinate, it'll be partial, and then the required will be
Oh,
10, the way we have it.
okay,
Right.
so this is fine as is, and then are we additional required fields? Is this where we would put the two SNOMED codes here, the umbilical vein and umbilical artery, and just say like use these codes to differentiate for
Yeah.
SPM? Okay.
Yeah. And then I was previously confused about the site umbilical artery in the comment, so maybe remove that in the comment row. I don't know where that came from.
Okay. A note of every. Sorry for going back and forth, back and forth. All right. Looks good.
Yep. I think SPM 10 should be empty.
Okay, yeah, that makes sense. Okay. All right, moving to, let me just double check real quick. Right. Next one, we have urine midstream straight cath. I'm gonna skip to the comments over here. Okay, new procedure term instead of collection of midstream specimen of urine procedure code. So was that supposed to go? Collection of urine via sterile urine. Okay. Exactly. So is that just adding that code? Is that what I'm understanding? Just adding
Yeah,
this
so
code?
what I remember about this was we went through all the different kinds of urine collection methods and none of them were in SNOMED. So Ricky entered or requested all of them for SNOMED. So they should be in SNOMED now. That was years ago. So it should be a straight cath collection. It's not, you do collect a midstream specimen because you put the straight cath in and you waste the first like 5 cc's, 10 cc's, and then you collect a midstream, but you're collecting it through a straight cath that you've inserted into the urethra, and you don't, you know, you get a more sterile or cleaner specimen that way than just doing clean catch mid-void. So there ought to be a SNOMED code for that now.
So we have, I'm not seeing anything that indicates a midstream or a mid-void biocatheter. I am seeing a collection of early morning midstream specimen by urine by clean catch, of urine by
Yeah.
clean catch.
Right.
And a collection of midstream specimen of urine. But those are the only two
Okay, so
midstreams.
so there's nothing
What about-
by straight cath.
What about
Well,
what about this
straight
one?
cath.
Yeah, obtained by single catheterization of urinary bladder. So that's a straight cath.
Okay.
Okay, though it sure as heck is not clear as that description.
Yeah, but
Or
that's a hold on. That's a specimen, that's not a procedure, and this needs to be a procedure.
Oh, sorry. Yeah, that's right.
okay.
So I think if we're capturing that context in the specimen, does it need to be in the procedure?
I don't know. Do you think we need to have a procedure that says that? It is a procedure. I mean, usually a nurse or a PA does it. Though people who have, you know, spinal cord injuries and stuff learn how to straight cath themselves. But usually it's done by a nurse.
But do we
So-
actually need to know the procedure? Or do we just need to know how it was collected? I mean, do we have to have a procedure name? Because we don't usually do procedures for all these we've been doing, have we?
Which segment does the procedure belong in compared to the specimen?
Well, that's what I'm thinking, that we don't use, I didn't think we'd been doing the procedures with all these filling in.
Well, specimen type, what's under specimen type? Because we do have a collection method, right?
Right.
So that's SPM 7. So the collection method would be, you know, urine obtained by straight catheterization.
Unless maybe this case is different, we have to have a procedure, but I didn't think we were doing that for most of these.
Well, we do have like how you collect a wound specimen, that kind of thing. Yeah.
So we do have collection of urine via straight catheter.
Okay. That's good.
So that would be, let me put that in the chat for you.
Okay, so SPM specimen collection and then SPM 7 description. Okay.
Okay, so then that would go here.
Yeah, so we had collection methods, if I'm remembering correctly, because some of them are sterile and some are not sterile, and we needed to know the difference.
Okay.
That's what I'm remembering.
Okay.
So
So
does,
specimen collection by swab, for example, you know, versus sterile collection by surgical, like a surgical collection.
Yeah, I think of surgical as procedure. I don't think of collection by swab as a procedure, unless I'm just not thinking correctly.
Well, it's a collection method,
Yes, I
which
think
is
of the
usually,
collection method, but not. Maybe SNOMED, we just, okay, never mind.
so
I
is
didn't think we were calling them all procedures. That's why I was.
is SPM4 for this specify sterile?
um,
Okay. Okay, it doesn't. Okay, I wanted to make sure that we didn't mix a sterile collection procedure with or a non-sterile collection procedure with a sterile specimen. Those should
right.
be kept consistent, and actually it would be really helpful if the decision was made whether sterile should be represented as part of the collection procedure or part of the specimen, so that that context is only captured in one location.
Okay.
Are we often doing it in both, or is it most?
I think if it's either or, it becomes difficult because then you have to try and be consistent, because I wouldn't want to see a sterile specimen that's collected by a non-sterile collection method. That could potentially, to me, be confusing from a data analytics perspective. If we're specifying it in both, I would want to make sure that they're consistent so that downstream users see it consistently.
Right, but you were just saying we ought to decide. I thought, well, if it's almost always done in one and not the other, we could.
Yeah, if we can't decide, then we have to represent it in both. But if we can decide, then it would be wise to choose where it belongs.
Okay, so I'm not quite following, John, sorry. But this is not considered a sterile procedure. So anything that you collect through the urethra, you're collecting through a contaminated area or a colonized area, I should say. It's not contaminated, it's normal to have it be colonized, but it's cleaner than collecting as a midvoid clean catch. So it's cleaner than that.
But isn't the okay, hold on, never mind. I think I'm getting my catheters confused.
Right. So the only way you can actually get a sterile specimen from the bladder is to do a suprapubic aspirate with a needle, which is how they do it with little tiny babies. You know, they'll do a suprapubic aspirate, and you can do it on adults too. It's just not often done. But that's really the only way you can get a sterile specimen, because you're bypassing the urethra.
Okay, so the collection of urine via straight catheter procedure that's in the chat would be the one that we would want to use in SPM7.
Okay.
And if the lab gets one that's labeled like that the procedure was a straight cath, then they will work it up differently than if it was a clean catch midvoid. So that's why we went through all of this originally, years and years ago, was because it does make a difference how you collect the urine, how you work it up, and how you interpret it in the laboratory.
So do we need to make another row for that? Or do we need to make a note instead for that? Well, I mean, if it's a straight cath, then it's going to be non-sterile, right? So
Well, it's going to be cleaner. It's not going to be totally sterile. But I can just tell you that from my perspective. I can't tell you exactly how you should model it. I just want it to be clear to the laboratory what kind of specimen it is, so they know how to work it up. So I'm relying on Manjula and you and John to tell me how you think it would best be modeled.
So Nancy, what was the distinction you made a minute ago, saying they'd work which two up differently? So
Right. So if you get a clean catch midvoid, you would work it up differently than if you got a straight cath from a patient.
okay, so but what I'm seeing now is just the straight cap. That would not be the clean clutch, clean mid. It wouldn't be.
Right.
So that would not fall on this line. So there shouldn't be confusion there. That would be entered some other way.
Right. So we do have a row for clean catch midvoid.
Oh, so we've already got both rows. I'm not.
Well, we already have that specimen in the table,
Okay.
in the specimen cross mapping table. We should have all of our urine specimens actually. Because
So
we
as long
went,
as we have
yeah,
both, it should be clear. It should be sent in as what it is, and it should be clear to the lab when they get it.
I hope so, yeah. Now, if you're doing a procedure, I mean, you're on the floor, you're doing a procedure, and you would say you're doing a straight cath, and that would go into the EHR, and you probably would have a different charge code for that, but I'm not 100% sure. So I think it needs to be clear on the floor too, like which specimen that they've collected for coding purposes.
And once again, if there's a way, and it sounds like there already is, there was already the other one in there. And if there's a way to do this one, as long as there's a way to do both, they can be sent in and we would know. But you shouldn't ever send one in on the other.
Right.
Okay.
Yeah, you wouldn't want to say on the floor, I collected a clean catch midvoid and then send it to the laboratory saying it's a collection via a straight cath, because that just wouldn't be true. John, are you agreeing with that, or?
I think mostly, but I'm not sure. It seems like this is consistent across what we're saying in 4 and 7. So I'm not sure.
Okay.
And Amy, can you roll back to what the name is on this row? Just want to make sure.
Oh,
Okay,
there
so
you
it is the urine. Okay, midstream straight cath. No, based on the flip preferred name, I think the specimen is midstream. Yep. And that, I think that is consistent with what we're saying in the SPM 7.
Okay.
Mm-hmm.
Okay. Yeah, it is. Okay.
Cool. All right. I think we should stop there.
Yes.
Because we're almost at time. Actually, I think these ones are the same as the first one we did where it says fields not finalized, but all the other fields are except this one. So I'll go and make that change, just change this back to orange so that it can be added. But other than that, I think we should stop there.
Okay.
Because we're out of time.
All right.
All right. Well,
Okay.
is there any topics or updates you want to anyone wants to bring up before we close the call?
Nope. By next week, I should have the wound culture part of the talk for January 7th done, and then Manjula and Ricky would work on that. So that's my goal.
All right, sounds good.
Okay.
Great. Well, thank you, everyone. I hope you
Great.
guys have a great rest of your day.
Thanks, you too.
You too.
Thank you.
Bye-bye.
Bye.
Bye.